The geriatric syndrome discussed during this presentation will be osteoporosis. Osteoporosis is a skeletal disease characterized by low bone mass, deterioration of bone tissue, and disruption of bone architecture. This leads to a compromised bone strength and an increased risk for fracture. Postmenopausal and age-related osteoporosis are the most common primary forms of bone loss that's seen in clinical practice. There can also be medication causes and secondary causes, which include hypercorticolism, hyperthyroidism, hyperparathyroidism, rheumatoid arthritis, Crohn's disease, premature menopause, alcohol abuse, and immobilization. Some medications that can induce osteoporosis include glucocorticoids, anti-seizure medications, heparin, lithium, proton pump inhibitors, as well as opioids. Osteoporosis is a major U.S. health condition and affects approximately 10 million adults 50 years of age and older, and an additional 33 million are said to have low bone mass. It causes more than 8 million fractures annually worldwide, and these fractures cause more than 420,000 hospital admissions and 2.5 million medical office visits. Family nurse practitioners are involved in all aspects of osteoporosis management. The patient chosen for this presentation is a 72-year-old female who presents to the office today for Medicare preventive screening, a follow-up on hypertension, and she needs her medications refilled. Her daughter is accompanying her today. She was last seen in March and her blood pressure was stable and controlled by oral medication. She's an established patient, been coming here for over 4 years. She perceives herself as healthy other than a few occasional aches and pains. She reports exercising 3 to 5 days each week and walking with her neighbor at least 30 minutes. She has received her flu and pneumonia vaccines and reports taking all medications as prescribed. Her daughter helps to get her medications ready for her each week in a divider. Her allergies include penicillin, which causes a rash, seasonal allergies to pollen and dust. She received all childhood immunizations, including meningococcal and influenza vaccine. However, she denies the Tdap, HPV, and Hib. Past medical history includes a radical mastectomy of her left breast and a right hip fracture, which was surgically repaired in 2016. Comorbid conditions is vitamin D deficiency, vitamin B12 deficiency, essential primary hypertension, hyperthyroidism, GERD, constipation, overactive bladder, abnormal weight loss, and breast cancer, which she was diagnosed with at age 42. This patient reports living alone and she feels safe in her home and neighborhood. Her daughter lives about 10 minutes away and she takes her grocery shopping, accompanies her to all appointments, and helps her around the house. I completed the home safety assessment checklist on this patient and it reveals her home to be safe. She was married for 38 years and has been widowed 10. She reports having a great marriage and raising 3 children. She has 2 sons who live in Kansas and California, and her daughter who lives close by. She denies being sexually active at this time. Her daily activities include cooking for her family, walking around the neighborhood with friends, keeping up with old friends on Facebook, and crocheting in her spare time. She attends church 2 times each week on Sundays and Wednesdays. She denies current alcohol or illicit drug use. A review of systems reveals an overall healthy Caucasian female. She denies any general fevers, weakness, fatigue, weight loss, or weight gain. She does experience numbness over her left breast where her mastectomy was performed. No chest pain, fatigue, edema. She does have hypertension. Blood pressure is always regular when she checks it at home. She's not sexually active at this time and she's satisfied with that. She's postmenopausal and experienced menopause at the age of 48. She's gravid of 3, para 3. Pertinent positives include back pain, which she has experienced for over 10 years. Health maintenance and disease prevention. She returned stool cards in May of 2017 for colon cancer screening. She had a mammogram in 2017 with no abnormal findings. Her most recent pap smear was in 2015 and no abnormal history. Osteoporosis screening. She received a DEXA scan in 2016 and is scheduled for a repeat in 2018. They are recommended every 2 years in patients with osteoporosis. She has no history of depression and was negative on her geriatric depression scale. She wears corrective lenses for reading. No history of skin cancer. Inspection of skin today showed no abnormalities. Lung cancer. She does have a history of lung cancer on her father's side and a history of smoking. She agrees to schedule a CT of the chest. Presentation and complications of osteoporosis include a long latent period before clinical symptoms develop. The earliest symptom is often acute back pain, pathologic fractures sustained after a fall, loss of height over time, as well as a stooped posture. Screenings and diagnostics for osteoporosis. As far as diagnostics, a DEXA scan is considered the gold standard in the diagnosis. An X-ray can also be performed, however, it lacks sensitivity to diagnose. An abnormality should prompt evaluation, such as a fracture. Ultrasounds can also be done, and they are good at predicting fractures in postmenopausal women and men older than 65. Labs that are performed are CBC, vitamin D, as well as calcium, phosphorus, magnesium, total protein, albumin, liver enzymes, creatinine, alk phos, and thyroid stimulating hormone. The objective data obtained reveals a weight of 124, height of 5'3", making her BMI 22, which is normal. All other vitals were within normal range. Assessment findings include back pain, use of proton pump inhibitors, history of high alcohol intake, history of smoking in a thin Caucasian woman. Screening tools used were the frailty tool. She scored a 1, which is pre-frail. Tinetti balance assessment tool. She scored 5, which makes her low risk for falls. Geriatric depression scale was a score of 2. And the home safety assessment tool was a score of 3, which reveals a safe environment at home. The final diagnosis for this patient is, of course, osteoporosis. Her DEXA scan revealed a score of 2.3. Anything less than 2.5 indicates osteoporosis. Differential diagnoses to consider would be hyperparathyroidism. You can rule this out by PTH levels, which would be elevated. Lack of dietary intake. This could be ruled out by checking vitamin D and calcium levels. Multiple myeloma. Symptoms of this is bone pain and anemia, as well as renal failure. Osteomalacia is softening of bones, which is most often caused by severe vitamin D deficiency. Alk phos is usually elevated, so you could rule this out by checking that. The main goals in osteoporosis include early detection. You want to assess present fracture status, determine any underlying or reversible causes, and monitor the effects of the intervention chosen. Lifestyle modifications can also help. Patients should receive an adequate intake of calcium, vitamin D. If they are smoking, they should quit. Exercise at least 30 minutes each day. Weight management if they are overweight, as well as fall prevention. The plan for this patient is to continue her Prolia injections, which she receives every 6 months. She has been getting these for 2 years now, and they seem to really be helping her. These inhibit osteoclast-mediated bone resorption. A DEXA scan is recommended every 2 years to reassess bone density, and she's scheduled for one of these in October of 2018. I'd like to assess the need for a proton pump inhibitor and provide education considering these can cause secondary osteoporosis and could be a contributing factor for her. I would also like her to be on a calcium and vitamin D supplementation. She stated that she was experiencing some back pain, however, she experienced it long term. I would still like to obtain an x-ray to assess her if she has a possible fracture. Health maintenance for this patient could include 30 minutes of exercise each day. She should avoid high impact or resistance exercises. Lower her salt intake with meals. Maintain adequate dietary protein, as well as increase her intake of fruits and vegetables. Resources available for patients with osteoporosis include the National Osteoporosis Foundation, home health care if needed, fall risk education, and nutritional education. Challenges and barriers could be medication adherence. Bisphosphonates are first-line therapy for osteoporosis. Patients who take this must remain sitting or standing for at least 20 minutes after with nothing to eat or drink, which could lead to medication adherence. They could have a lack of understanding regarding the asymptomatic nature of osteoporosis, and the morbidities associated with untreated osteoporosis could result in a challenge. The multidisciplinary team for the treatment of osteoporosis includes the primary care provider, osteoporosis specialist, nutritionalist, physical and occupational therapist, home health care, as well as pharmacist. Behaviors for this patient includes an active lifestyle, a history of excess alcohol intake, as well as a history of smoking and long-term use of a proton pump inhibitor. Socioeconomic or cultural issues that could occur include the lack of proper nutrition, retirement and income, language and literacy, and access to health care. This patient lives alone since her husband passed away. However, she does have her daughter close by for help. Legal and ethical issues that could occur with this population include elder abuse, which can result in injury or fracture. As the nurse practitioner, you want to properly manage your with osteoporosis and follow up with appropriate scans and interventions. By doing this presentation, I learned that osteoporosis is the most common bone disease in humans. As a primary care provider, you should perform bone mineral density testing 1 to 2 years after initiating medical therapy, and then every 2 years thereafter. Providers need to recognize the risks, counsel patients on how to reduce them, and become more vigilant in screening for osteoporosis.